Welcome to the Symposium organized by Medtronic on today's surgical AVR patient. Many things have changed over the last 10-15 years with the introduction of transcatheter aortic valves. However, there's still a large number of patients that need to be treated with surgical AVR. Today, we're going to discuss contemporary approaches for lifetime management. I'm joined by an esteemed faculty, François Dagenet from the Quebec Heart and Lung Institute, Dr. Joe Bavaria from the Hospital of the University of Pennsylvania, and Michiel Vriesendorp from Leiden University Medical Center. First, we want to open this discussion with a slide that shows you what the things that have changed over the last 10-15 years. And Dr. Bavaria will show you a graph that is really food for thought and food for discussion. Dr. Bavaria, for you is the first slide and to comment on this one.
Well, thank you, Peter. These are my disclosures. Okay, so this is an interesting slide that comes from the STS database as well as the TVT database in North America and is actually a melange or a blend of these two databases. It's kind of, I call it the aortic valve universe from 2012 to 2019, which is the last data dump. What you see here is incredibly interesting regarding the entire aortic valve usage on the entire continent. And what you can see here in the red line is the growth of TAVR in the United States. And you got to remember that this data is in the TVT database. So this is mandated by the United States by law. So it has to, you have to enter in the data. So these numbers are real, or else you don't get paid. Okay, which is a critical thing. So these numbers are quite real. The only data that's not put in here is data from clinical trials. So the STS database is the other numbers. So you can see that the transcatheter valves in the red line have just gone up and up and up. And you can see the other lines, which is the blue line, which is the total aortic valve, surgical aortic valve numbers in the US. And then there's these other lines down below, which represent isolated aortic valve in green, aortic valve CABG, as well as aortic valve other, which are basically the same almost. And then this blue line down in the bottom is composite grafts, in other words, aortic root procedures, and the red line is wheat procedures. This is what we're going to talk about a little bit later, which is a combination of aortic valve plus ascending aorta, and then the lowest line is aortic valve repair and not replacement. So you can see if you add up all these lines, you get to the top blue line. So there's a couple of key points here. So what this shows is that TAVR for the first time in 2019 surpassed SAVR in all of its forms, as you can see here. It surpassed isolated AVR in 2016, as you can see here. Now, isolated AVR, which is this green line, was pretty steady for a while, but has come down recently, especially in the last year with the introduction of low-risk AVR, a low-risk TAVR, I should say. And you can see it's about a 15 to 20% reduction. But it's not as bad as we would have thought. But what's really interesting from this data set is that CABG AVR, and especially AVR other, has stayed pretty flat. AVR other is AVR with all of the other things that we can do, such as a double valve or a AVR with a maze, or AVR with anything but a CABG, basically. But that portion of our business of what we do is actually pretty flat. What you can also see is that AVR as a part of an aortic root procedure is actually going up about 10 to 15% a year over the past 5 or 6 years, and is doing nothing but going straight up. So I suppose the point of this slide is to show that the surgical AVR universe is still quite robust, and in some respects is actually increasing, although isolated AVR is not, and that TAVR, of course, is proceeding along in an exponential fashion.
It's fascinating, Joe. So what do you think is the reason that the mental procedures are going up?
I think the Bentall procedures are going up because number one, I think we've trained more surgeons that to be able to do these operations, and they're coming out in a steady clip, so that's one reason. The second reason is I think that adherence to the guidelines and just taking patients who have combined aortic valve and aortic root and ascending aortic disease is becoming a little bit better understood. So I think it might be a guideline effect as well. Those are the two main reasons.
Right.
Also, there's an organic growth of about 6%, 4 to 6% per year.
Right. So last month, the guidelines were published from the ACC/AHA. Do you think that these guidelines will have any effect on these graphs, these curves?
I'd love to see what Francois has to say about this, but I think that there may be. I think that the indications for surgery for aortic valve insufficiency are a little bit more realistic in the guidelines, so that's an important point. From the STS database, pure AI represents about 11% of all aortic valve operations, so that's an important component, and that's just pure AI, not mixed ASAI. So I would wonder what Francois would have to say about that.
Francois, do you see similar trends in Canada as well, and the influence of the guidelines?
Yeah, well, I think we're seeing more and more patients refer now earlier for pure AI, and I think it's good in itself. I think we're also now seeing more of the aortic valve as a disease in itself, and I think we'll have to learn in the next years, to probably having a better timing for these procedures, and also to better assess, when we do, let's say, just a standard AVR, to better guide for future therapies thereafter, like a height of the coronary arteries and such issues that will allow us to treat these patients probably in a more longitudinal fashion and as a team approach that we've learned for the last 5 to 7 years.
Right. And in Canada, are the surgical AVRs, let's say, surpassed by TAVR?
I think we're about 50-50 now. So, but we're seeing this rise as everywhere else, and I think it has led us to have a very, how can I say, team approach in these kind of pathologies. And I think it's a reality. And as Joe said, I think we see more and more root procedures with surgical AVR, and I think that's important to, as a surgical community, to better deal with these procedures.
Right. Well, Joe, it's hard to predict future, but what do you think with the blue line? How will that be in 2025?
I think that my personal opinion is that we're going to see a slight decrease further in isolated AVRs as a percentage, and the reason for that is that the full impact of low risk TAVR has probably not totally been felt yet, although the guidelines were not quite so favorable to low risk AVR as one might have thought. So if you read the guidelines pretty closely, there's no class 1A indication at all for TAVR in low risk patients. So I think that it'll go down a little bit, but then I think it'll flatten out for a while, mostly until we get a better understanding of low risk TAVR, which is not fully kind of developed yet from a data and outcome standpoint.
I think we will move on to the first more formal presentation, which is by Michiel Vriesendorp, who's going to talk about prosthesis-patient mismatch, a concept that has been introduced by Rahim Tullah already many years ago, I think in the 80s. And there has been lots of discussion around how should you select the right prosthesis for the right patient. And so, Michiel, I'm giving you the floor now for your presentation.
My name is Michiel Vriesendorp, and I'm a resident from Leiden University Medical Center. These are my disclosures. The first question I would like to ask you is, how do you select the right valve size for aortic valve replacement? Is it A, using a prosthesis with a projected index EUA above 0.85, or B, a prosthesis with a projected index EUA above 0.65, C, always a prosthesis size larger than 21, if necessary with concomitant annular enlargement, or D, according to the largest valve size that fits in the annulus? If you would look to the literature for an answer, it would suggest it's either A or B, as it's the definition of moderate or severe PPM. But today I want to demonstrate some limitations of this concept. So a little background on the concept of prosthesis-patient mismatch. In theory, it is present when the opening area of the prosthesis is too small in relation to the transvalvular flow of the patient. This results in hemodynamic obstruction similar to native aortic valve disease. In practice, this relation is determined by dividing effective orifice area of the prosthesis by the body surface area of the patient, and the resulting index effective orifice area is subsequently used to classify patients as having no PPM, moderate PPM, or severe PPM. So a lot of studies have looked at the association between PPM and survival. And while some studies found a negligible impact of PPM, I think the consensus is that PPM is associated with a significant higher risk of mortality, which is also reflected by this large meta-analysis published last year. And this result, among others, has led to the recommendation to use valve charts to guide the valve size selection in the operating room. And whilst these valve charts are an easy to use tool, there has not been any evidence from randomized trials that has shown that the use of these charts over just ordinary valve sizers has led to better survival. So while there is an association between projected PPM and poor survival, this does not necessarily mean that when projected PPM is prevented, that this automatically results in better survival. This in turn requires a string of assumptions I want to talk about today. First of all, projected PPM, according to the chart, should correspond with the presence of PPM postoperatively. This in turn is assumed to be correlated with the presence of elevated gradients, which is in turn believed to reflect a pathologic degree of hemodynamic obstruction leading to poor survival. And while these assumptions are critical, there's surprisingly little evidence to support them. So with the use of the data from the Paragon pivotal trial, which was a pre-market approval trial for the Medtronic Avalis, we questioned these various assumptions. To start off, the accuracy of valve charts to predict PPM. For example, if we look at the patients who underwent implantation with Avalis size 23 in the Medtronic Paragon trial, we observed a wide range of effective orifice area values at the 6 months follow-up visit. However, for a new valve chart, only the mean value would be used. So when we split up the Paragon trial in two separate groups, a training set and a test set, we created first a new valve chart and tested it in the test set. We observed a poor correlation between projected index effective orifice area and measured index effective orifice area. In addition, almost a third of patients were being misclassified with the new EUAI chart. This includes almost 21% of the patients with a false positive prediction of PPM. These patients would be at risk of receiving an unnecessary annular enlargement. So based on these results, it may be a little bit preliminary to say that projected PPM corresponds with the presence of PPM postoperatively. In addition, the association between PPM postoperatively and the elevated gradients can be questioned as well. This assumption has been explicitly based on this figure published by Pibaro and Dumas-Neal in 2000, in which they found a strong exponential relation between index effective orifice area at rest and mean gradient at rest. In addition, also on this figure is a cutoff value for PPM 0.85 based, as it corresponds with the point where the increase in mean gradient accelerates. However, there are some limitations to this study. First of all, it was a small single center study, and in addition, they used a variety of prosthetic valves. So on the left-hand side, you see represented by the black dots, stented bioprosthetic valves. But in addition, they also included stentless valves, pulmonary autografts, and homografts, with limited overlap in index effective orifice area between these prostheses. So therefore, we decided to validate this relation in a cohort exclusively based on stented bioprosthetic valves. This pooled data set originates data from both the Paragon trial, but also from the surgical cohort from the low-risk trial, the Certavi trial, and the high-risk trial. And in contrary to the findings by Pibaro, we found an almost linear relationship between index effective orifice area and mean aortic gradient. This complicates the selection of any cutoff value for the definition of PPM, as there is no clear point where the increasing gradient accelerates. So also when a patient has PPM, it's not clear that he also has elevated gradients. And even for elevated gradients itself, it's not clear which cutoff exactly reflects a pathologic degree of hemodynamic obstruction leading to poor survival. So this brings us back to the first question, how to select the right valve size for aortic valve replacement. Based on the inaccuracy of valve charts to predict PPM and the classification of PPM to reflect hemodynamic obstruction, we would like to argue that you shouldn't use projected index EUA to guide the size selection. An alternative approach is to always implant a prosthesis size larger than 21. However, a size 21 is just a label and not an anatomic dimension. This complicates the generalizability of this rule among different prosthetic models. So therefore, we recommend to guide the size selection according to the largest valve size that fits in the annulus. This is a simple technique, but we think it's the best option. There's no reason to undersize, and if we would oversize a valve, it would require concomitant annular enlargement, which brings its own trade-off between new risk and benefits. And while some observational studies have suggested annular enlargement is safe, there's no evidence from randomized trials that have shown that concomitant annular enlargement leads to improved survival over conventional AVR. In absence of such evidence, we therefore recommend to always implant the largest valve size that fits. But I look forward to hear your opinion about this topic. Thank you.
Thank you very much, Michiel. Well, absolutely, let's say your controversial conclusion and your option number D, and we have two well-experienced surgeons here on the panel as well. So, Joe, what are you doing if you select a valve size? Which of those four would you choose, or do you have a fifth one?
I have a four with an asterisk, or D with an asterisk.
Okay.
So the fact of the matter is that I totally agree with this in principle and in concept, that I don't even care about any of these things except for D, which is I've placed the largest valve that I can put in. So I agree with that. Now, second thing I agree with is that you almost never need an annular enlargement. And in someone like myself, and I'm sure maybe Francois may be similar, because we do so many aortic routes, that if I need to do an annular enlargement, I personally anyway, I'm just going to do a route, okay? Because I can do a route and it's more elegant and it's faster than an annular enlargement. Okay, so, but here's where I differ, and this is like advanced aortic valve implantation technique, which is the annulus does not make any difference whatsoever in a supraannular valve. And this valve is a supraannular design valve. What you really want to know is put the largest valve that actually fits in the root, not the annulus. The root is defined in this particular case as the answer to this question. Does this valve have a coronary obstruction when it's placed supraannually? And does it have any issues with crowding of the STJ if it's in a supraannular position, which would affect diastolic blood flow into the coronary? So these are the two questions. And if the answer is yes, that this is okay, that we have good coronary situation and we have a good STJ situation, then you can put that valve in. And what that usually means, not always, and I'm going to show a little special case of that later, that usually means you can upsize one. So what I usually do is I put in the barrel size sizer through the annulus, upsize one, ask the question, does this valve fit in this route? If the answer is yes, then I put in that one extra sizer. If the answer is no, which is what happened in the case we're going to see, then I put in the size of the barrel sizer. So the replica sizer is actually more important than the barrel sizer. So that's my approach. Francois?
Great, yeah.
And I totally agree with you in terms of the replica and barrel sizer. I think one aspect is I agree with D, although I think in some patients a small annuli is something that's a reality. And I think this is why we have to see the disease as a team approach. And I think now if you have a projected small annuli, I think those are patients where TAVI, I think, have benefits also to consider, especially if they're a small operative risk. So basically, I still will perform either a root or an annulus enlargement and use the projected EOA in young active patients to really make sure that I have optimized the hemodynamic profile of for the patient. But most of the time, I will try tried to fit in the largest valve sizer. And I think each valve has their specificities. And to be able to optimize the valve sizing, one has to really know the characteristics of the valve that they're using.
Absolutely.
Yeah, I would say that it's D, but instead of using the word annulus, I would use the word root. The largest valve size that fits in the root. Whenever I do a root, I can almost always upsize the root by 1, and many times upsize the root by 2.
Yes, I agree with that for sure.
So Joe, do you also look at the LVOT outflow tract?
Yeah, that's the one place where I agree with Francois. My decision based on TAVR in these patients is based on the LVOT. If you have a really small LVOT, I totally agree. Those are better TAVR cases. But it's pretty rare actually to have an LVOT that is flow resistant or has much of a gradient across it. So if you hang a valve up supraannually above the LVOT, even if you have a 20 millimeter LVOT and you put in a 21 or 23 millimeter valve, you're not going to have much gradient across a 20 millimeter LVOT. A little bit, but not much.
Right. So what is your recommendation in those people who don't routinely perform root procedures, but just do surgical AVRs?
I would say just put in the a supraannular valve, and just kind of like what you said, which is you don't really need to do a root enlargement that often, and put in a solid supraannular valve. You can usually upsize it 1 and get a good result.
Great. Well, that leads us actually a perfect introduction to the next topic from François Dagenet on also prosthesis-patient mismatch. But he has a different view on this now, that he has exercise patients who came after a surgical AVR.
Well, thank you, Peter. And I think Michael's interesting talk will have important issues in the upcoming talk. Well, I will discuss a bit further the hemodynamic profile of the AVLS valve at stress. These are my disclosures. So there have been good clinical outcomes with the AVLS valve through the Paragon trial, now having outcomes at 4 years. However, quite surprisingly, there's been a high rate of moderate to severe PPM in the Paragon trial, with up to 2/3 of patients that show moderate to severe PPM at resting echo. However, paradoxically, about 2/3 of patients showed that had severe PPM had prosthesis size that were 23 or larger. So with this discrepancy between the good clinical outcomes of the AVLS valve and the high rate of moderate to severe PPM found at resting echo, we defined what we call the PPM conundrum of the AVLS valve. So just a few variables on the clinical impact on this PPM in the Paragon trial. If we look at 2 or 4 years, the freedom from all-cause death was similar for all levels of PPM, as well as the improvement in functional class was comparable for all levels of PPM. When focusing on mean gradients, we see a rise in mean gradients, but the rise seen for the severe PPM group was much smaller than one would expect if we had a true severe PPM. In fact, also, if we look at LV mass regression for either no, moderate, or severe PPM, we see the same range of LV mass regression. So are we truly facing PPM with the AVLS valve, such as documented in the Paragon trial? So to better understand what's happening with this valve in terms of hemodynamic profile, we decided to conduct a stress exercise with echo monitoring in 30 patients. At a mean of 2 years post-implant of the AVLS valve. So this was done on an ergo cycle. Resting echo data were obtained for a measured index TOA, and following this, increments of 25 to 50 watts were performed for every patient with sequential echo data acquisition. So within these 30 patients that we selected within our cohort of the Paragon trial, 12 patients had no measured PPM, 12 patients had moderate measured PPM on resting echo, and 6 patients showed severe PPM. There was a trend in smaller valve sizes in the severe PPM group. BSA were comparable around 2 for each groups, and the maximal heart rate was obtained in up to 80% of the maximal heart rate in the 3 groups, with a pretty good exercise level in the 3 groups. So when we focus on the rest and stress echo data, one can see in terms of stroke volume that there's a significant increase for all levels of PPM. On the other hand, there seems to be a trend in having a lower stroke volume in the severe PPM group, which, however, in terms of percent increase during stress, maximal stress, has the same percent increase than the other PPM levels. If we look into the flow rate, we see similar findings in a sense that we have an increase in flow rate at maximal exercise, but with also a tendency to have a lower flow rate at rest in the severe PPM group. When focusing on the indexed EOA, we see a significant increase in indexed EOA for all groups, suggesting that the AVLS valve has an increased opening, which is flow dependent, thus an opening reserve to increase in cardiac output. This shows differently the increase in mean gradient during maximal exercise. As we see in most bioprosthesis, there's an increase in the mean gradients at stress. And however, if we focus on the severe PPM group, the increase in mean gradient is probably much less than one would expect if we had a true severe mismatch. This slide illustrates a bit differently the increase in indexed EOA that was found at maximal exercise. So we see a significant increase in indexed EOA at maximal exercise for all levels of PPM analyzed. And if we reclassify the PPM levels at maximal effort, we see that no patients at that moment had a severe PPM, and now 23 patients compared to 12 had no PPM, and 7 patients had moderate PPM. This increase in indexed EOA was also found for all valve sizes. So this slide depicts the increase in EOA with increasing flow rate at exercise for the 3 measured PPM levels. We see an increase in indexed EOA, which is flow dependent. And if we look into the opening reserve of each level of PPM, this is comparable for all levels of PPM, suggesting an opening reserve for all these 30 patients that are comparable. Now, to better understand why at rest we have a high rate of moderate and severe PPM for the AVLS valve, we decided to look into the impact of having low flow at the resting echo. So we divide the cohort into 2 stratums, with one group having low flow defined as under 250 cc's per second of flow. And we see right out the bat that there's an increase in severe measured PPM in this group, which is related to the decrease in stroke volume, thus less flow across the valve, so the valve opens less, and showing at that point lower indexed EOA, probably suggesting why we have this high moderate to severe PPM, mainly linked to a low flow stroke volume, a low stroke volume at rest. However, once again, when we do maximal exercise, we see an opening of the reserve of the valve with going out of the range of the moderate PPM level in terms of indexed EOA. So the last question we wanted to try to answer is how reliable are the projected or estimated PPM chart to predict the valve performance for the AVLS valve? So when we look into our 30 patients, the estimated or projected PPM for our cohort, 11 patients showed no estimated PPM and 19 patients showed moderate estimated PPM. No patient showed severe estimated PPM when we put them in the chart. So essentially what the take-home message is that we see this opening reserve in both no estimated and moderate estimated PPM. However, the opening reserve is significantly increased in patients with a no estimated PPM situation compared to moderate estimated PPM situation. This slide, once again, tries to see if the estimated indexed EOA as suggested by the chart predicts the hemodynamic profile at stress of the valve. We see for patients that have low flow at rest in red, a tendency to have a decrease in the measured EOA at rest, suggesting a low flow state in these patients. But when we stress these patients, we see that the indexed EOA is either identical or superior to the estimated indexed EOA, suggesting that the estimated indexed EOA is a reliable predictor of the valve performance at maximal stress. So basically the lessons learned, the take-home message of this trial is that the good clinical results of the AVLS valve seem to be supported by an opening reserve of the valve at exercise. The opening reserve is present at all levels of PPM and valve sizes. Thus, the PPM observed at rest echo in AVLS valve patients with good functional class is probably a pseudo PPM and not a true PPM, especially if you have a low to normal measured stroke volume. Thus, this underscores the importance of conducting a stress echo if a true PPM is suspected in an AVLS valve patient. And finally, the estimated PPM, as suggested by the AVLS and nomogram PPM chart, is reliable to predict the hemodynamic performance of the valve at maximal stress of the future implanted AVLS valve, and that the opening reserve is significantly increased in a no estimated PPM situation. So basically, this hemodynamic profile of the AVLS valve is quite unique, and in terms of the impact on the clinical outcome, it still remains to be defined. Will this have an impact on durability? Will this opening reserve be maintained with time? Those are important questions. So we're planning future studies to evaluate a larger number of patients with moderate to severe PPM and valve sizes, and also to reevaluate opening reserve at different time points. And finally, to correlate also the opening reserve with CT imaging, mainly in terms of valve thickening and calcification. So thank you very much, Peter, and I'm glad to answer any questions or comments.
Great. Well, thanks very much, François. Great data, and also great that you took the exercise test to the next level by testing how those prosthetic heart valves behave during exercise. I think it has always been in the mind of cardiologists, surgeons, that if you have a gradient address of 15, 16, 17 millimeters of mercury, that gradient would go up to a level that is unacceptable. And you have shown that there's something else with surgical valve prosthesis, that this kind of opening reserve, which I think is a very novel concept. So Joe, does it give you a little bit more confidence in the performance of surgical heart valves?
Yeah, well, certainly the AVLS valve. And it's an incredible finding, to be honest with you. It kind of takes, as you said, it does two things. It takes the analysis of the whole concept of PPM to another level, but also in a negative standpoint, it kind of says, well, maybe we really don't understand PPM as well as we thought we did. So this is really interesting stuff. I have to admit, first of all, I don't know if this has ever been shown in any other valve. Maybe Francois can answer that. This certainly, I will certainly do exactly what he said, which is to get a stress echo if I find an AVLS valve in our patients that shows a significant PPM, just to make sure it's real. So this is very interesting, kind of next gen sort of analysis. Congratulations. I'm looking forward to more information coming out on this entire concept with all surgical valves?
Well, to answer your question, I think your question is very valid, Joe, in terms of is this a unique to the Evolus valve? And when you look at either Ross procedures or native valve, they open fully, right at the minimal stroke volume. If we look into bioprosthetic valves, probably the only prosthesis that has been shown to have this kind of opening reserve was the trifecta valve with the outcomes that we know. But basically, this concept of the valve is quite unique, and it's really part of this valve hemodynamic profile, since we've seen this in all the 30 patients we've analyzed. So it's very consistent. However, will this be maintained with time, or will this have an impact on decreasing wear and tear? It's going to be interesting to see. But one thing for sure, and I'm sure in your hands also, is that when you reoperate a patient for severe mismatch, which is quite rare, but when you do that, you better be sure your diagnosis, because these are operations that are not necessarily always easy, and the outcomes are not always very good if we don't operate them for the right reason. So I think we still have to learn a lot on mismatch, and I think the debate is still open, even though I can tell you the debate was initiated here in my hospital.
Yeah, that's interesting. Do you think it's pericardial tissue versus, say, porcine tissue?
Your question is good. I think this valve is a very low profile, the Evolus valve, as you know, and in terms of also the posts are rigid but have a certain amount of flexibility. So I think it's like a bit of a trampoline. So I think it opens up more a flat configuration, and I think this is why we see this opening reserve, because of the profile of the valve and the kind of rigidity or a bit of the post require a certain amount of force maybe to open up compared to other valves. So I think it's in the concept of the valve that we see this kind of opening reserve that where it lies.
Perfect. So Michiel already pointed out the fact that prosthesis-based mismatch is not so easy and has several limitations. Michiel, maybe you have a question.
Yeah, I have one question to you. In contrary to gradients, index EOA is often believed to be a flow-independent parameter of hemodynamic performance, but I think your results clearly show it isn't, and index EOA increases as flow rate increases. What do you think is the added value of using index EOA besides mean gradients and peak gradients for the assessment of hemodynamic performance of Medtronic Evolus, for example?
So I think, if I understand well, the question you're asking, so what are how do we use the gradients per se in when we evaluate the hemodynamic performance of a valve? And I'm sure that Joe will agree with me that gradients, once again, are very difficult to judge, in the sense that you'll do the same valve in a Bentall procedure or in a native aorta. Just the aortic compliance or having a graft will influence greatly your gradients you're going to have through the valves. So depending on if you have high pressure, also I think are issues. So I think gradients have their value, but it's not the 5 millimeters of gradient that are going to change something to say that a valve is superior to another in terms of hemodynamic profile. On the other hand, I think you've shown it well in your slide when you say that when we take the projected or the estimated EOA, it's a mean of different EOAs for a one valve size. And this shows that there's variability, and this variability is probably due to different factors of flow through the valve, which can depend on the opening reserve, like we said, of the valve, but also on the hemodynamic conditions where the echo is done. So I think this shows that there are many parameters that we have to take into mind, and it's just not we have a number per se that we have to look into.
Great, thank you very much. And I have one more question. You said that estimated ppm had a relation with the degree of opening reserve. Were there any other patient characteristics associated with less or greater opening reserve?
Well, I think that those are interesting questions. We mainly focused on the echo data now, and we'll see. I think it still is a limited cohort of patients, 30 patients. I think it gives us a good trend to see how the hemodynamic profile of the valve is. But I think doing further studies like the CT data will give us, I think, if with time, on valve thickening and calcification to see if this has an impact on this opening reserve. I think this is going to be a very interesting study to perform to establish, like you say, are there other criteria or other variables that influence this opening reserve?
Great. Well, thanks very much. And great discussion and a very interesting topic. Because of time, we also have to move on now, I think, to the last presentation from Dr. Joe Bavaria, which also shows us a video of a procedure, the WEED procedure. So I'm happy to introduce Dr. Joe Bavaria, Vice Chair of Penn Cardiovascular Surgery, University of Pennsylvania, who's talking about the WEED procedure and using the Medtronic Avalus valve.
Well, thank you. My presentation is on aortic valve replacement with an ascending hemiarch and the AVR with an Avalus valve. This is just a case presentation to kind of put everything into perspective. So the case presentation in general, it's a 65-year-old male. There is characteristics. He's got a bicuspid aortic valve with hypertension, and he's got class 2 congestive heart failure with a little bit of shortness of breath as well as dyspnea on exertion. The anatomy of the case is that he has a 4.7 centimeter ascending aortic aneurysm with an STJ measurement of 27 millimeters, but a pretty small SOV diameter of only 32 millimeters. So it's one of these ascending phenotypes of the BAV presentation, and a little bit more of an explicit ascending phenotype. The root is actually small, so it's kind of an interesting situation. He's got moderate AI with severe AS, pressure at halftime of 393 and a mean gradient of 33. So we've got mixed ASAI with an AVA of 0.9 and a normal ejection fraction. Regarding the valve, he's got a bicuspid aortic valve with a Sievers 1 right-left fusion. Severe aortic stenosis is very calcified, typical of these bicuspid valve AS cases. Reduced mobility of the non-coronary cusp and the right cusp both. Left coronary cusp prolapse, this is resulting in the eccentric AI that we see. Here's an echocardiogram, and the echocardiogram shows a couple of things. The AS, you can see, the AI as well. And note that this is an ascending phenotype with a relatively small SOV diameter and a partially calcified STJ, as you can see on these echoes. This is going to actually be an important consideration when we do the valve sizing. So the surgical indications this is a mixed surgical indication, valvular and aortic. The symptomatic aortic stenosis is probably the primary operative indication with moderate AI. The 4.7 centimeter aorta is not a primary indication, but a secondary indication, according to the guidelines, both aortic guidelines and valvular guidelines. The challenges and considerations regarding this case is that the main surgical issue with this case is related to the relatively small SOV diameter of 32 millimeters. Of note, his annular diameter was 27 millimeters. Do we perform a WEED procedure or a root procedure to possibly allow for a larger valve? To resect the calcified STJ or not, even though it's normal diameter or even smaller than normal? Is a biobental an easier future TAVR anatomy than a WEED procedure under these anatomic constraints? These are the things we have to always think about with every case. Kind of next-gen analysis. So our surgical approach in this case was to do an aortic valve replacement with 25 millimeter Avalus 400 valve with a supraannular placement. We did a transverse arch hemiarch with a 26 millimeter graft and an ascending aortic aneurysm repair with a 28 graft. Our bypass time was 211 minutes with an RCP time of 22 minutes. I generally do RCP for short circuit rest cases and ACP for all complex circuit rest cases. And so here's our video. So as you can see here, we have a 4.7 centimeter ascending aorta, and we placed the cross clamp. I will narrate as we go. This is the opening of the valve and of the aorta. As you can see, we're resecting the this ascending portion. This is an ascending phenotype. And here's our dissection. This is in the Ross plane and posteriorly here. Now, this is the aortic cut for the Wheat procedure. I take the cut usually 5 or so millimeters above the STJ. You can see this kind of very defined STJ in this BAV case. He has robust STJ definition and a little bit of a rim of calcium, as you can see. And when I cut these, I'm going to think about where I'm going to put the sutures, not where I'm going to make the cut. So this is the valve analysis. It's a heavily calcified and thickened bicuspid aortic valve, as you can see. So you can see that that's not something we're necessarily going to save. We're going to cut this valve out. It's pretty heavily calcified. So we excise the valve in a kind of a standard fashion. There's the raphe, which is heavily calcified as well. Make sure you get all the calcium because the calcium load in these valves is quite substantial. Make sure you don't drop it in the ventricle. This is a debridement. You can see this incredible heavy subannular calcification. That's pretty amazing, as you can see there. Again, this is pretty typical of bicuspid aortic valve. You can see AS cases. Kind of makes you wonder how you can put a TAVR in some of these patients with these asymmetric calcification. But here we had a 27 millimeter valve, and as you can see, that replica sizer was not going through very easily. This is a 25 here, and the 25 sizer went in, but it just goes to show you that this root is kind of interesting. This root is pretty small, and it's smaller than what we would normally see. And this is kind of a biological, kind of embryological cleft in this BAV phenotype that we see with ascending phenotype sometimes, where the root is small and the ascending aorta is big. So here's a superannular placement of the sutures. I generally put pledgeted sutures in, and we're going to go to the arch now. This is a standard hemiarch operation, and we're going to take it all the way to the innominate orifice. But at this stage, like a lot of bicuspid cases, the arch is pretty normal. If you look at the embryology of BAV, generally it does not go past the innominate artery, so we have a nice, aorta at this level. I size this to a 26 millimeter graft with a slight bevel hemiarch, as you can see. I use a fluoroproline BB suture, which is a long suture, you can see that we intussuscepted the graft into aorta. This is a standard procedure I use for all my aorta cases, proximal and the distal intussusception, so that it's kind of like a Chinese finger trap, where actually the higher the pressure, the more tight it gets. So it's an onlay anastomosis as opposed to an end-to-end in a fashion. So here's the end of the suture. I usually put a little bit of sealant on these, just a couple of cc's. In this particular case, I'll recannulate the graft. I use a 6 millimeter cannula here, so it goes in nice and easy. Sometimes I'll use a sidearm, 8 or 10 millimeter sidearm graft. The cross clamp is now reapplied. We de-aired the whole graft with retrograde. It was only a 20-minute RCP run for this hemiarch. Now we're back to the valve, and you can see this is the Avalus valve, and it's very nice and easy to put in. When I put a superannular valve in, I put the sutures towards the outside of the sewing ring. When I put an intraannular valve in, I put them towards the inside. I usually don't use pledgets in the commissures because they bunch up and cause an increased gradient. So I use pledget sutures elsewhere, though. Now you can see that this valve is a little bit tight in here. We knew it was going to be a little tight. It's a 32 millimeter SOV, and this is a 25 millimeter valve, but it fit okay. This was a little bit different than Mikkel's original concepts that we're talking about. We sized this valve to the annular size and did not upsize one because our root didn't fit. Remember, we talked about that. The root, it didn't fit in the root as a 27. So we put this 25 in, which is plenty big enough for him. We use a core knot to tie these down. I use a core knot on almost all AVRs. It's just, simple, fast, and reliable. it looks pretty good after we're done here. You can see we put a check for the coronary. We always check for coronaries, the right and left coronary. Make sure we have good STJ inflow into the sinus segment, especially in this case where we have a tight SOV. Now I'm sizing for the ascending graft. I usually put in a size bigger than the valve. This was a 25 millimeter valve, and we sized it a little bit bigger. So I put a 28 millimeter graft in here. I would never put in a 24 millimeter graft, for example, when I put in a 25 millimeter valve. So this is a primary suture line, which goes right down to the STJ. We use a fluoroproline running suture with a BB, which is a nice thin, long suture for this wheat procedure. We then actually do this little maneuver, which I like, which is I give cardioplegia down this new route, this neo-aortic route. This does three things. It gives cardioplegia, tests the valve, and tests our suture line, a little bit of sealant. Now we cut the graft for graft-to-graft anastomosis. I usually do this with two separate cuts from a standpoint of geometry. I do a 110-degree cut in the AP position, and then another 110-degree cut in the towards the left side, so that we have a simulation of the normal curvature of the ascending aorta. Again, a little sealant on the graft-to-graft, total of 8 cc's for all of them, just one of those things. And then we're ready to go to take the clamp off and complete the operation. And you can see we have a nice simulation of the ascending aorta as it goes into the arch. We have a de-airing vent in place. Everything looks pretty good. So that's a video. Let's go to the next slide. So outcomes in this case, we had trace AI. It was kind of pixels. We had a mean gradient of 13. This was at discharge. We actually had a later echo, which was even less in a better environment with less cardiac output. Discharge home on POD number 6, and patient did quite well. Here's you can see the valve. It's we got no real AS there. You can't see any aliasing, and we have the diameters as you can see here. This again was a tight route.
Excellent.
Thank you.
Yeah, perfect. So Joe, some people, and hopefully not on bicuspid patients, but if they have a dilatation of the ascending aorta, they just take a piece out of the ascending aorta and suture it together again. Is that a good idea or a bad idea? Would you do it?
Yeah, I would only do that in a, I call that an aortoplasty.
Yeah.
That's something that I would only do in aortas that are between, say, 40 and 44 millimeters. In other words, lower than the guideline directed aortic therapy. You know, the aortic guidelines as a class 2A indication for aortic replacement is if you have a 46 or greater millimeter aorta while you're doing the aortic valve. So I tend to do that occasionally in certain patients who fall below that, but I don't do it very often. I don't know what Francois does.
Yeah, Francois, do you do that?
No, I don't do that. I would do like Joe says, I would do an arthroplasty in probably very, very selected cases. But I think if you decide that you want to, I would replace with the Dacron graft most of the cases. I think it's a very nice, elegant video that Joe proposed us. And I think the take-home message, I think also is that the Avalus valve, I think, is a very nice valve because of its low profile for such a weak procedure. And this case is a bit unusual, as Joe pointed out, in terms of having a sinus of the non-fused sinus that is not very dilated. You'll see more usually a dilation there that you can resect, let's say, just with the Dacron patch and open up at that point your sinotubular junction and probably put in a larger valve. But I think the use of a replica here for the Avalus valve is very important, especially if you, let's say, have a very calcified bicuspid valve, especially if you're not doing a weak procedure, that the use of the replica is very important for your valve sizing.
Correct.
Yeah, I think the replica is more important than the barrel size.
Well, thank you all very much. Great discussions today on this symposium. And if there are any questions, please leave them in the chat box. And thank you very much for your attention.